Now, ladies and gentlemen, we begin with the next segment of session to health insurance, in fact. Amplifying impact by leveraging the scale of government with efficiency of private sector, ladies and gentlemen. And this session will be moderated by Mr. Amit Mookim, MD of IQVIA. The experts, let me introduce him briefly. Very briefly, I will introduce. He has been introduced this morning. Mr. Amit Mookim has been a management consultant, turned into a business leader, and currently oversees the India operations of IQVIA, which is a global healthcare technology, information, and clinical research organization. Warm welcome again, sir. Let me introduce the experts of this session. Dr. Harish Pillai, CEO, Aster India. Now, Dr. Harish Pillai, ladies and gentlemen, is a doctor with exceptional leader skills. He joined the Aster DM Healthcare Group as the CEO of Aster MedCity, Kochi in the year 2013, and his ability to strategize and manage large-scale healthcare organization helped Aster MedCity consolidate its place among the top hospitals in the country in just a span of 1 year. Very warm welcome to you, Dr. Pillai. Let me introduce Mr. Jack Langenbrunner, the Senior Advisor and Health Financing Expert, Government of Indonesia. He's a health economist with both research and operations experience. He has worked in India since 2015. He was a senior officer with the Bill and Melinda Gates Foundation from 2015 to 2018 and with the New Health System Transformation Platform in 2019 and 2020. Warm welcome to you, sir. Let me now introduce, ladies and gentlemen, Mr. Owen K. Smith, Senior Economist of the World Bank. And he is a senior, ladies and gentlemen, he is with the World Bank's Health, Nutrition and Population Global Practice based in New Delhi since 2016. He joined the World Bank in 2005 and has worked extensively on health financing and health policy issues in Europe and Central Asia and South Asia regions. Warm welcome, sir. We have with us Dr. Prakash Subbarayan, MD, Star Health and Allied Insurance. Very warm welcome to you, sir. He's a passionate medical doctor who became a managing director of a leading health insurance company for the first time in India. He's the first of its kind to have 2 decades of clinical experience from India and overseas, and having more than a decade of experience in health insurance. And as a managing director of Star Health Insurance, he's making commendable contribution for the progress of Star Health Insurance through the synergy of 12,000 plus network hospitals and diagnostic centers in India. Warm welcome, sir. With that, I will now hand over the proceedings of this session to Mr. Amit Mookim. Sir, please, all yours.
Thank you, Aishwarya, and very good afternoon. I hope I'm audible. Welcome to my fellow panelists, and I actually had the opportunity to join in a little earlier and was listening into the amazing discussion that was going on, and I was thinking it fits in so well into the conversation we as a group have been having for the last few days on what we wanted to discuss in front of this forum today. With me, I have the most appropriate configuration here with Jack, who spent a lot of time in India and is joining us at 3:30 a.m. from Washington, D.C. Jack, thank you so much. You look the freshest of us all. And Owen, of course, who's been based in India via the World Bank, so he has seen the entire journey of universal healthcare rollout as well as before. And then, of course, Dr. Harish, who's been across the world in running hospital facilities and now based in India, a great friend and an amazing leader, as well as Dr. Prakash, who runs one of the largest payer organizations in the country. I wanted to start with a very open-ended question, and maybe Owen and Dr. Prakash, if you can help set the stage. And this question is around the UHC, right, or the Universal Healthcare Coverage Initiative that we have embarked upon. And given that our journey of UHC has begun only a few years ago, and by no means are we well underway, directionally, and let me repeat that word, directionally, do you feel we are heading in the right path? Any one of you?
I can begin maybe if you like. Can you hear me?
Yes.
Thank you, Amit, and thank you to NatHealth for giving me this opportunity to join this great panel. So directionally, is India going the right way? I mean, I think at a high level, I would say yes. You see in middle-income countries like India around the world, health becomes a more salient topic. It becomes more a part of the public discourse. You see new reforms happening. All of this is happening in India. There's the Ayushman Bharat scheme launched 3 years ago with both the Health and Wellness Center component and the PMJ component. You see much more public discourse around health, whether it's in government documents or in the regular general mainstream media. I think at a system level, middle-income countries make a transition along many fronts, and India has started several of those. So one is the transition from supply-side financing to demand-side financing. All countries pretty much go through this transition. PMJ embodies that transition, and I think that's happening, and that's the right direction. There's a transition from a fixation on the public sector towards private sector and seeing the opportunities and the potential of the contributions of the private sector. I think PMJ also is helping move that agenda along, so that's the right direction. There's been a focus on the poor and vulnerable segment of the population through targeting, and we want to aim towards universality, but to start with the lower end of the welfare distribution is also a good direction. Now, having said all that, speed and direction are different things. I think speed remains to be seen on a number of these fronts. I think a couple of the transitions in middle-income countries that are not yet really getting enough momentum in India. Firstly, the transition from out-of-pocket financing towards government health financing. I think that's just starting a little bit, but a long, long way needs to go. I think everyone knows that India's government spend on health is relatively low. It's around 1.1% of GDP. I think a more telling figure is the share of the government budget. And by this, I mean consolidated, both the union government and state governments. The share of the government budget going into health in India is less than 4%, which is extremely low by global standards. It's like in the bottom 10 or 15 in the world out of almost 200 countries. Looking forward, if we want to see is the direction, the right direction, we really need to see the government spend coming up and crowding out the out-of-pocket. And the last thing I would say is that the transition from focusing on access to the focus on quality still really needs to emerge. There's a long, long way to go on that. Right now, it's about getting people registered and eligible and so on, and now the focus really needs to shift.
Amit, if I can also pitch into what Owen said, I find it interesting from a political point of view that what we have seen with the previous minimum income scheme, the NREGA scheme, a lot of political capital was invested in that project. So from a paradigm shift, it's really good that our country has invested political capital on creating a safety net for a large amount of our citizens. And we have seen that around the world, countries who have invested in social sectors, in education and health, it has got a percolation effect going forward on GDP growth due to a creation of a healthier and I would say a knowledge-based kind of society. Within our country, we have pockets of data. It's mainly in the southern states, which have really gone forward for investing in social sector. So from a directional point of view, what you asked, this is a fantastic move by the government of India, and it will set a strong foundation for new things to happen in the future.
Thank you, Dr. Harish. Dr. Prakash, any views from you?
Yeah, thanks, Mookim. And universal health coverage, to my knowledge, as a medical student in 1984, I was told that national health policy was endorsed by the parliament in 1983. And the target we set was by 2000, we should have universal health coverage. It was pushed to 2002, and still in 2021, we are discussing about it. So I just want to say that we have to be strong. We got to be strong in getting that into reality. And we have been discussing a lot of time about this. And universal health coverage, one important aspect, I'm very thankful to the government for initiating this objective and taking it forward. But what I see as a big gap is that a sort of reluctance by qualified and experienced healthcare professionals and popular hospitals to participate in this universal health coverage. This can happen only through a partnership between public and private. So private hospitals which have the expertise and capacity to cater for life-saving treatment should come forward and work for universal health coverage. In India, when we want to look at the hospital beds, we should not look only at government hospital beds, including private hospitals. All beds offering healthcare services should be taken into account, and the participation should be uniform, because in India there is always a divide between rural and urban, and these differences in quality of services have to be addressed through the universal health coverage. Just want to say one thing: of all inequalities in healthcare is most inhuman. And unfortunately, in our vast healthcare system, there remain many differences in quality between rural and urban. I just want to say that I'm willing to join the government and the initiative to see that how we can make it and bring it into a reality.
Thank you, Dr. Prakash. Let me pick up what you mentioned about the private sector uptake, which was my second question to this panel. And we all know that, if you look at the two key pillars of making this happen, one pillar is building access, the other is also creating a robust financing model, right? And in a country like India, there is no silver bullet, simple solution to this. But reality of the fact also remains that we have not seen as much uptake of the private sector and participation. And you mentioned this as an issue, right? We know that costing and pricing has been one whole piece. Is there anything else beyond that, or is that the only issue in your view? And maybe Dr. Harish, you run a provider chain on the private side. Maybe your views will be very, very welcome, and anyone else who wants to share their views.
Thank you, Amit. Firstly, we need to recognize that our country is a subcontinent, and the size and complexity of us is perhaps much higher than the European Union. So when we look from a united, if you look at United States of India, so to speak, we have so many different micro markets where the cost of care is varied. So it's very difficult, and I think it's a bit complex to assume that a one-size-fit-all strategy in terms of pricing of a specific product will really work. I can give you multiple examples, whether in terms of input costs for hospitals, whether it's utility costs, which are controlled by the state electricity boards currently. There's so much from state to state. Secondly, if you look at manpower costs, which is the biggest chunk sitting in the hospital P&L, it of course based on the market and of course demand supply gap of the availability of consultants in that. So the challenge what we face when we have the current methodology of USC is that the costing has not really taken into account these kind of variations within the country. Yes, as part of nation building, all of us would be very keen to come on board if there is a rational costing methodology which addresses these genuine concerns. Specifically, that we need to understand that bulk of the private providers, this has come, from a different source of funding itself. It's I would say that not without any support from regulatory agencies or the government in terms of subsidy for acquisition of land or even the capital cost of the project. So while we say that healthcare is a strategic sector, it also has to have a certain incentive for providers to be engaged continuously. Plus, we look at the economics of the entire reimbursement model. It'll be very difficult to reach large amount of providers to come on board.
No, Dr. Harish, let me push forward my question, and maybe I'm being a little provocative here, and for this group. If the cost angle was taken care of, is there anything else that would have prevented or addressed this whole issue of empanelment, or is it just the cost angle?
No, if you ask me from our networks, if you, it's predominantly the cost angle, which is the biggest source of concern. See, the biggest we should look at from a supply side point of view. There are huge advantages for any payer who can guarantee consistently a certain volume of cases, and we know that if you have that consistent volume of cases, your fixed cost will anyway get diluted. And it's a question of bringing in operational efficiencies to derive of it. So really speaking, that the big elephant in the room is costing. If the costing aspect is addressed, then I think you will have more private players coming on board to support the universal health scheme.
Any other comments from any panelists before I move to the next point on this?
I agree to the views of Dr. Harish, because the cost is the limiting factor. But in this context, how to arrive at an appropriate cost? How to suggest the patients to go to an appropriate hospital and not an advanced hospital for a common ailment, because that increases healthcare cost. How to bring in quality so that we can prevent readmission, infection rates that can reduce healthcare cost, and how hospitals can have a lean management strategy and a financial dashboard to see that with the volumes that they get out of the UHC, how they can moderate the cost. So cost is an important factor, and the cost can be brought down. And we as payers, we have the experience of paying close to 6 million claims to the tune of around 3 billion rupees in these 14 years. So definitely we can guarantee that we can support the government in making this more appropriate and helping the government to achieve a standardization of cost.
I have one more point to support what Dr. Prakash had mentioned. This is basically taking off from the discussions of our earlier panel. The big hole in the current healthcare delivery reimbursement model is that IRDA does not cover for ambulatory care or outpatient. And yes, in terms of early acceptance or adoption of insurance products, mostly the age band is also skewed towards, let's say, 35 plus. So, morbidity patterns also result in costly curative reimbursement for the payers. So I think there has to be a national resolve to increase early adoption at the younger age group. Therefore, the cross-subsidization can take place across demographics. And that it is very important that the gatekeeper concept, where primary care needs to be supported, because bulk of the burden which currently goes to tertiary and quaternary care centers, that can be easily managed. And like rightfully mentioned by the earlier speakers, if you have data points about disease patterns at the ambulatory care, there can be a lot of wellness and preventive interventions which can be enforced upon the individual subscriber through incentives or tax breaks, whatever we can think about to reduce the burden of disease overall.
No, absolutely. And let me bring in Jack over here. Jack, this is a question for you, given your wide global experience, right? And in my mind, in any universal health program, engaging the primary care sector is an imperative, to the point that Harish is also mentioning, right? But the reality of the situation in India is that we have a completely fragmented, uninsured primary care setup. There are many, many private sector companies who try to do these but have not been successful. Private insurance doesn't cover it today, and the infrastructure that the government has needs significant upgradation. So how do we move from here on with respect to linking in direction, speed, and everything else?
Amit, and thanks for the opportunity to be on the panel. It's a pleasure to work with all of you, and it's an honor to be invited by NatHealth. Let me pick up on your question. I mean, I think the private sector certainly needs to play a role. And indeed, looking at your neighbors, such as Indonesia, where I'm doing some work now, India's families will probably prefer private primary health care. In Indonesia, people have been given a choice to sign up for a PHC organization, and the majority, let me repeat, the majority have voted with their feet and moved to the private sector. I would say, it's probably due to features like responsiveness, efficiency, and probably its clear edge on looking for and accepting innovation. So I think it's a good model to look at. And let us take a PMJY program as a start. What can a platform like the National Health Authority do? what can they do to integrate PHC and bring in the private sector? At the outset, Owen mentioned moving from supply side to demand side, and I would agree with that. Pool more funds under the National Health Authority. I would like to see, for example, the NHM funds begin to gravitate to the NHA platform. Once that money is pooled under the purchaser arrangement, then you can do several things. Number one, identify and agree on the benefits package. If you're going to buy care, you need to know what care for the money. Likewise, providers need to know what they deliver according to their contract. The package can be adjusted. It can be adjusted for urban, for rural, for tribal areas. It can certainly increase over time. We could start with a relatively small package. But without a clear package, the NHA will not be able to buy effectively, and PHC providers will not be able to organize. And they will need to organize and reorganize probably a bit. Which brings me to my second point, establish the supply side basic requirements. Let's be flexible, but we must develop some minimum input standards. Organizational structures, as I say, may need to adapt. And here the innovation of the private sector, I think, can really shine. Use your accreditation organizations to review and to verify. Make sure these accreditation bodies are unbiased between public and private. Third point, develop your IT platform. Simple and basic to start, just as we're doing now with hospitals and inpatient care. From my vantage point, India does probably have the best capacity in the entire world for digitization of the sector. So I'm excited on that point. Fourth, develop contracts and payment models, capitation, fee for service, pay for performance. It may be a blend for pushing value for money care. And I like the concept piece that NatHealth has put out. Easy to read, and it gives you some insight into how things are going in other countries, including the US, and how India might adapt to using a value for money concepts. Fifth point, develop your monitoring and quality review system. Accountability always counts. And finally, and I'm sorry to be so long-winded here, Amit, especially in the urban and semi-urban areas, allow choice of provider and have an open enrollment season each and every year. This forces all providers to pay attention. No signups by consumers and families, no money from the NHA and SHAs. So from my vantage point, these are just a few relatively straightforward steps. I'd like to see India get started along these lines. And I'm quite optimistic going forward. To be frank, I think the health and wellness centers, while it's a nice announcement, the models initiated a few years back are not probably going to be very successful. They're going to need to restructure, especially if they wish to compete. And again, I'm at a level playing field. A level playing field will show all of India the strong interest in using primary healthcare from the private sector. Over to you.
Thank you, Jack. You mentioned an interesting point, which I want to ask Dr. Prakash, which is around benefits, packages, and products. And where are we in the journey, Dr. Prakash, to be able to get this adapted and launched in India? Because we don't have it today, right? I mean, to the earlier panel also, a lot of the products on insurance are only hospitalization based, even on the private side. What will be your view and outlook on that?
That was a very good question. Insurers in India, insurers are annoyed about the loss ratios because the coverage is currently available for hospitalization and daycare procedures. But still, the loss ratios on group, government, and retail insurance and the combined ratios are not allowing the insurers to have a profit margin. So naturally, there is a lot of apprehension for insurers to cover areas like OPD or what Dr. Harish was suggesting. If insurers should have that cushion of covering all those untapped areas like outpatient, like dental, delivery, pregnancy, and all that. if insurers have to cover all those untapped areas, then naturally a sort of support by the government. Insurers do want to cover people who are physically challenged, people who are already suffering from an ailment. For example, close to 70 million people are diagnosed with diabetes, and a lot of them are pre-diabetes in India. And most of these people are prone for target organ damage. But people with a disease are denied of an insurance cover in India. If this has to be allowed, then I think insurers on the whole will expect a support from the government to standardize the treatment cost so that they can comfortably come with a pricing for the product. Affordability is a big issue in India, where people are not willing to spend for their health insurance. They don't want health insurance as a protection. They want health insurance as an entitlement. If they want to pay money, they want to get something out of it. But insurance is a concept where you have to pay for your protection. So this adoption of the public at a larger perspective has to happen. And there should be some price modulation available so that insurers can appropriately price the product and come with an affordable insurance cover. So your question is very right. There is a need for insurers to come forward with such products which can address the untapped market. But these products have to be more affordable. Only then we can have the buying capacity in India. And for this to become affordable, there should be some healthy platform created between payers and providers so that they can arrive, and there should be some cost study done so that we can arrive at a win-win situation where both of them can agree on a price by which common procedures and life-threatening situations can be handled. Based on that, insurers should create a very, very affordable product.
Thank you, Dr. Prakash. Harish, a question relating from for you from this, right? You've seen networks, you run networks across the world where you also have clinics, you have other outpatient ambulatory care, and then you have hospitals, right? Now, if you had a product like this in India for you, in your mind, what would be the practical challenges of getting it to work?
So currently, we are in the paradigm of inefficiencies. When you look, I mentioned in my earlier remark about overhead costs, but we need to be honest here and be more transparent on assessing what are these overhead costs. So there is a huge group, huge scope for bringing in efficiencies at all parameters of running a hospital. Like the example, what I would like to quote about is in Dubai, where Aster is a predominant provider. We are the largest primary care providers in UAE, specifically in Dubai. We also have secondary care hospitals. So in that market, because it's 100% insurance dominated, the segmentation is at ABC category based on your reimbursement options. So we have boutique brands positioned to cater to all these segmentations as ABC. But however, right now, Dubai has moved already into the DRG based system. It's a diagnosis related group where it is extremely important for you to bring in not just operational but clinical efficiencies, where your clinicians cannot practice the way it was before. It has to be all based on evidence-based medicine. There will be outliers where you need to predetermine those kind of comorbidities before the patient is admitted. But inefficiencies, for example, if you do not have a standardized antibiogram, if you don't have an antimicrobial stewardship program, if that results in a hospital-acquired infection, which causes a delta in your average length of stay, then obviously the cost has to be absorbed by the provider. So in order to bring to India, we have to get our act together. It's very important when we look at reimbursement based on an outcome-based model. So a lot of work has to be done, but I guess when you look at the crystal ball and look at India in the year 2025 and beyond, there is no option but providers to become more efficient and more disciplined. This window, what we are all feasting on about out-of-pocket cash patients, that is going to shrink. The biggest catalyst which COVID has provided to our citizens is that you can't let your health to providence. In fact, you have to go and become more, adopt insurance packages from a family or from an individual point of view. There's also a big shift from the formal and informal sectors of the economy also to give some sort of an insurance for the employees and their family. So I think overall, the kind of behavioral change of consumers is a big positive. And I'm 100% sure that providers overall will really tighten the belts and become more and more efficient.
Absolutely. Thank you for this, Harish. And this is a question for anyone in this panel. But to the point Harish was mentioning about last year's pandemic, I think one of the debates or open questions is, we were on a journey on the universal healthcare program, right? And then this pandemic hit, and we all recognize that we have also in some way drip-feeded this program. So has this pandemic strengthened our trajectory, or has it taken away some of the focus and firepower? And the reason why I ask this, gentlemen, is that to some extent, there's been a lot more adoption of digital. There's been some acceleration of certain regulations that were long overdue, right? But at the same time, the pandemic has put a lot more pressure on our system, and hence this question. So would love your views across the panel.
I can start, Amit, with just a few comments. I really think the pandemic has shown us, and I think we've mentioned this earlier in the panel, and I agree, how important healthcare and public health are and will be in our lives. So I think the pandemic has been enormously helpful in this way. And, you know, I see a lot of new pharma innovation, obviously with the vaccines, new technologies, as you mentioned, such as telemedicine. And I really think it has forced providers to be a bit more efficient and certainly more equitable in the sense that we're all in this together, right? So lots of good impacts that way. And I have gone to webinars in India and other places, and I really see that it's been the private sector leading the way with innovation. I think the challenge now, Amit, will be for the public and the social insurance-based purchasers to integrate these innovations and these new approaches to care, and to really bring in these new ways of doing things into the public benefits package, the benefits package that I referred to before. And I think this will be very important, as every country, including India, will face some level of fiscal shock, certainly this year, and certainly probably in 2022 and 2023. Back over to you.
Thank you, Jack. Any other comments from anyone?
Yeah, I have a point that one big delta point for 2020 is the increased adoption of digital across the entire spectrum of healthcare delivery. When you look at some of the big push, mainly to do with e-pharmacy, e-diagnostics, of course, the virtual care platforms. What could not have happened in the previous couple of years just got a booster dose thanks to COVID. And we increasingly we are talking about omni-channel adoption or the brick and click model of care. And I'm also glad that a couple of reimbursers, like when you look at CGHS, now CGHS already covers for teleconsult, virtual teleconsult. So those are all early signposts of a big shift towards innovation, which I think is going to be sustainable in the near term.
Thank you, Dr. Harish. I think we've got a few minutes, but I wanted to ask one more open-ended question. And before that, the only point I would want to make regarding this pandemic-related situation, to me, I think it's put a lot more spotlight across countries on the responsibility that the government has in shaping and driving the infrastructure, right? I think we passed through a time frame where a large part of healthcare delivery was driven by the private sector. And that is a reality, I think, that private and public will continue in India. But I think the pandemic put a lot more spotlight on how this whole agenda is being shaped together and a lot more direction is being provided. I mean, that's at least the way I look at it on what's really happened here. And just segue into my last question for the last few minutes, and where we started from, Owen, you mentioned about direction and speed. Interestingly, I think you did mention the point around speed not being there as much as it would like, but I think a lot has been spoken about direction as well. to be candid. And I think, those nudges that we need to make on direction. And if we had to change or enable one area for the next 3 years, whatever comes on top of your mind to strengthen our journey, what would it be? And please don't say costing. Costing is covered.
Healthcare. Sorry.
I think, if we're talking about the lessons of the pandemic, I think not just for India, but globally, it's clearly the need to focus on the core functions of public health, disease surveillance, and a lot of this is sort of boots on the ground of local government. And I think that's something that has been neglected all around the world. I think another area that the pandemic has really highlighted is the neglect of urban health. I think certainly the government system is always focused on rural areas, and there's a need to really rethink how to sort of organize urban health services. But if you're saying one thing for the next 3 years, I won't say costing, but I'll come back to what I said earlier, which is governments need to start pushing more of their budgets into health. The pandemic, as Jack said, has made the fiscal situation much more difficult, and especially at the state level, I think. But ultimately, while we really see a lot of role for the private sector on provision when it comes to financing, voluntary private insurance just never really takes off in any country. It really comes down to, it can play a nice niche role, but ultimately governments are going to have to start allocating a larger share to the sector. And then that's what the next 3 years should have a good focus on. Thanks.
Thank you.
I totally endorse the views of Owen, and I think there should be more of healthcare budgeting to be done, and to make this budget very effective, we should look at standardizing the cost. That's a well conveyed point. Thanks, Owen.
I have a point that assuming that we will touch 5% of GDP for healthcare, that's an assumption which we have to make over the next 5 years. We need to create more resources, which we found sorely lacking in the pandemic, which started last year. Like we need more epidemiologists, we need more infectious diseases consultant. We need definitely more bandwidth in the diagnostic field, whether it's molecular diagnostics. These kind of niche areas, I think, is very important. Last point, which I feel that, like what we do, the advanced monsoon forecasting, we need to use the ability of AI and machine learning towards forecasting much in advance the next epidemic clusters or pandemic, which could emerge. These would be my wish list. Thank you.
Great comments from the panel, and I certainly agree with what's been said. Very quickly, Amit, again, sorry to sound like a bit of a broken record, but start moving more of the public sector funds into the NHA pool from the National Health Mission and other sources. I think once we start doing this, once we start removing the current supply side subsidies from the public providers, which can run very high, sometimes as high as 60%, as an add-on, then I think we can start paying the same amount for the same service, the level playing field approach. And I think this is something that we need to do for both public and private. With that new level playing field, then we need to measure who does well, update, and buy from your best providers as these emerge with time. Thank you. Over to you, Amit.
Thank you, Jack, and I think you did a great job of summarizing as well. And I know Aishwarya's back, and we are out of our time. Gentlemen, it's been an absolute pleasure, not only this panel, but interacting with all of you throughout the last few weeks. I have personally learned a lot. It's obviously not an ideal situation to imagine an audience behind us who we are speaking to and no questions from them. But I do hope that this conversation was of value. Dr. Harish, thank you. Dr. Prakash, Owen, Jack, thank you very much. Over to you, Aishwarya.
Thank you very much. Thank you to the panelists for their valuable opinions. And thank you, Mr. Mookim, for steering this conversation ever so brilliantly. Thank you very much.